Lecture-Articulations, also known as joints. Okay, so joints, I guess, joints is the common name, right? The anatomical name is articulations, chapter 8. So let's go ahead and talk about the types. Excuse me. Types of joints and the functions of joints, and how they help in movement, right? Because joints, that's what joints are for. They're for movement. So the reason why I chose to go ahead and cover joints in between bones and muscles is simply because joints are like the transition from bone to muscle, if you will. Right? It connects both. It connects. They connect muscle to bone, and they allow for movement, essentially. Right. So without joints, you don't have movement. That's as simple as that. So this is a very, very important topic right here. All right. So several functions of joints: enable movement, stability, right? Provide stability to the bones, and then they also indirectly allow long bones to lengthen. Okay. So you remember hopefully the epiphyseal plate, right? So epiphyseal plate is one type of joint. It's a subtype of joint. So keep in mind that the plate elongates from when we're born all the way to age about 20, 21, give or take. Although some people, rarely, there's always outliers, right? Sometimes people stop growing earlier, and then other times people, don't stop growing until later. But again, those are outliers. On average is 20, 21 years of age. Okay, so several classifications of joints. We have synarthrosis, no movement at all; amphioarthrosis, limited movement; diarthrosis, free movement. Synarthrosis, no movement; amphioarthrosis, limited movement; and then diarthrosis, free movement. Okay, so three major general classifications of joints, right? The rest of the PowerPoint here is going to go ahead and hash out the differences between each one, and then all of these subtypes of each one of these. Okay, so three classifications in terms of structure. Okay, so in terms of structure, we have three classifications: fibrous joints, cartilaginous joints, and synovial joints. So the name kind of gives it to you, right? The name kind of gives it to you. The structure of a fibrous joint, right, is going to be made of evidently fibers. Yeah, so if you recall from histology, we said that fibers are mostly made up of collagen. And that's what they are, that they're collagen bundles of the dense regular collagenous connective tissue, right? So keep in mind these very strong collagen bundles that if they're used within fibrous joints, they create a very strong type of joint. Okay, so which might not have a lot of movement. Cartilaginous joints, as the name implies, has a piece of cartilage in between the bones. Already, so this one can allow for a little bit of movement, limited amount of movement. I'm sure you can think of at least one example of a cartilaginous joint. That would be the vertebrae. Yeah, so the space in between the vertebrae contains a pad of fibrocartilage, right? So again, that's a type of cartilaginous joint. Then we have synovial joints. Synovial joints are freely movable joints, like your shoulder joint, right? Your hip joint. They carry on with all types of movement you can think of, right? Like a flexion, an extension, abduction, adduction, protraction, retraction, all types of movement, even circumduction, right? Rotation. is also done by synovial. So lots of movement in synovial joints. Now, the name here doesn't necessarily give it to you, okay? But if you recall from histology, actually no, from week 1, introduction to anatomy, we talked about synovial membranes briefly. And then I mentioned that they were lined by synoviocytes, which are specific types of cells that create this synovial fluid, right? So I guess that's the difference between synovial and these two. That synovial joints contain fluid in their membranes. Okay, so there's a membrane that's similar to a cavity, right? Inside is fluid. It's called synovial fluid. So, I'll show you guys what that's composed of in a bit. Okay, so let's look at fibrous joints real quick. The sutures that occur in the skull bones, they are known as fibrous joints. So again, sutures, I'm sorry, right? So these joints are immovable. They don't move at all, right? So they go ahead and allow for pairing of skull bones, like for example, the two parietal bones, the frontal bone with the parietal bones, the occipital bone with the parietal bones and temporal bones, right? So that's what sutures are for, right? So they're immovable joints that fall under the fibrous joint category. Okay, so again, what type of was this? This is dense collagenous tissue, dense regular collagenous tissue. Kyphosis is another very specific type of fibrous joint. It occurs in the teeth essentially. So it's going to go ahead and join together the teeth with the gums. Okay, so the teeth with the gums. Notice this periodontal ligament right here. Make sure you note that one down, please. It's going to be very important in holding the teeth to the gum. So keeping that thing stable. Evidently, another type of immovable joint in which you see fibers as well, right, connecting the tooth to the gum. Syndesmosis is another type of fibrous joint. Okay, so a syndesmosis is also known as an interosseous membrane. Again, it's also known as an interosseous membrane, and it occurs between in the space in between two locations in the body. Right. So first, the upper limb, right in between the radius and the ulna, we have these ligaments here, this network of ligaments, which hold the radius and the ulna horizontally together to prevent too much movement between the two. Right. But nevertheless, there is limited movement from radius and ulna. Right. The radius basically crosses over the ulna when you go from supination to pronation. Okay, so I'll show you the example in a bit. The other place where this occurs is in between the fibula and the tibia. Okay, so the fibula and the tibia, which is the lower leg, if you will. Okay, that one is a lot less movable than if it even moves at all, right? Than the forearm, but nevertheless, right, they're held together by interosseous membranes. So very strong connection there. So that was the fibrous joints right there. Let me show you a quick, brief animation of it.
Maybe. The bones are bound by a tough, fibrous connective tissue. These joints exhibit little to no mobility. The types of fibrous joints we're going to talk about today are sutures, gomphoses, and syndesmoses. Firstly, we have sutures, which are fibrous joints found exclusively between the bones of the skull. We can see a nice example in our illustration here, which is a coronal suture. This suture connects the frontal bone to the parietal bone via sutural ligaments. Next, we have a gomphosis, which is found in the mouth, where the roots of the teeth articulate with the dental alveoli at the dental alveolar joints. The tooth is bound into its socket by the strong periodontal ligaments, which we can see here highlighted in green. Lastly, we have a syndesmosis, which is formed by ligaments and a strong membrane that holds two bones in place. We can see an example of this here, where the interosseous membrane runs between the radius and the ulna. The last type of joint we're going to talk about is the cartilaginous joint. In a cartilaginous joint,
all right, so let's go ahead and get to that one. The cartilaginous joint, right? So this one is composed of cartilage, and we have two types here, subtypes. One is called a synchondrosis. The other one is a symphysis, right? Synchondrosis, symphysis. So the synchondrosis, right, is made up of mostly hyaline cartilage, and it occurs in the in two places: epiphyseal plate, that's one, which is the proximal end and the distal end of long bones, and then it also occurs at the ribs. Okay, two locations within the ribs. One is the sternocostal location, which joins together the sternum to the ribs, but more specifically, the sternal cartilage to the rib. The other one, right, the other location is the costochondral joint, which is basically the opposite side of the rib cage, right? So sternocostal is the sternal side. Costochondral would be the other side, right? Which is the vertebral side, if you will. Again, the name of these is a synchondrosis, and very limited movement, but nevertheless there is movement. The epiphyseal plate allows for the elongation of the bone. So here we have the synchondrosis here at the epiphyseal plate, which we've seen in the past. And then here is the other type, the costochondral, and the one that occurs from the sternum to the actual rib itself. Okay, so we have a symphysis as well. So a symphysis, as mentioned before, is made up of a fibrocartilage pad, and it occurs in two locations. One is an intervertebral joint, and the other one is a pubic symphysis. Alrighty, so the intervertebral disc, or the joint right there. This is the space between the vertebrae, which is, divided by this piece of this pad of cartilage here, of the fibrocartilage type. Okay, so the reason for us having it there, sorry about that, is because it resists compressive forces. So all of the weight, right, from the upper body rests on the body of the vertebrae, which transfers the weight onto the piece of cartilage, onto the next vertebrae, to the cartilage, to the next vertebrae, and so on, right? It also allows for the movement of the vertebrae. Now, the pubic symphysis is located in between the coxal bones of the pubic bone. Recall that the pubis is made of three bones, right? Here we have the sacrum, coxal bone on the right, coxal bone on the left, and these two are joined together inferiorly by the pubic symphysis. Oh my God, I'm sorry about that.
do you feel all of your axes they can move along. Joints that can move. These joints can be subclassified into two types. This membrane runs between the radius and the ulna. The last type of joint we're going to talk about is the cartilaginous joint. In a cartilaginous joint, the bones are connected by fibrocartilage or hyaline cartilage. These joints can be subclassified into two types, synchondroses and symphyses. First, we'll talk about a synchondrosis or primary cartilaginous joint, where the bones are connected by hyaline cartilage. In a histological image, we can see that this type of joint is found between the diaphysis and the epiphysis of a growing long bone and will eventually become completely ossified in adulthood. The second type of cartilaginous joint is known as a symphysis or secondary cartilaginous joint, where the bones are connected by fibrocartilage. This type of joint is found primarily along the midline of the body, for example, the pubic symphysis, which we can see here highlighted in green.
Texas homeowners, if you have a power meter like this on the side of your house.
Right. Okay. There it is. So we've looked at the epiphyseal plate, and I believe we've talked about epiphyseal plate fractures. These occur mostly in children, right? Again, because that space in children is elongating at any given point, right, in childhood. Therefore, it's easier for that place to tear apart, if you will. Okay, so now moving on to synovial joints. These show the most diversification here. We have many subtypes of synovial joints. First and foremost, there's two structures to the synovial joint. There's a joint cavity, also known as a synovial cavity, and articular capsule, right? Those are the two main structures to the joint. The articular capsule is going to be made up of an outer fibrous layer that is stabilizing the bones of the joint, essentially, right? So as you're moving them, as muscles are contracting, this outer fibrous layer keeps the bones from being pulled apart, essentially. And then you have the inner, membrane, which is lined by synoviocytes. And then inside, deeper inside is synovial fluid. Okay, so these are the three functions of synovial fluid. First, lubrication. That fluid is going to go ahead and lubricate the entire membrane, synovial membrane, where it's located. Second, it's going to go ahead and also transport nutrients and waste products. So it's going to go ahead and move them around within the cavity. And third is possibly most important one is shock absorption. Okay, so to evenly distribute the weight, the force as you're moving around, right? Because movement is very complex, right? There's a lot of dynamics to movement. We don't move necessarily just in one way, right? There's many aspects, many dimensions to movement, and therefore the importance of the synovial joint. So here it is. Here we have the articular capsule right around the bones. This particular one is the knee joint, right? So here we have the femur, here we have the tibia, the fibula. You don't see it in this image, right? But you also have a kneecap right here, otherwise known as a patella. So the joint is a bit more complex than I'm showing it, but I'm just kind of showing the synovial space, right, in this diagram. So this is the synovial membrane. Notice how it lines the entire joint. It's lined by synoviocytes, which are they're generating the synovial fluid, which you're looking at there, okay, in blue, essentially. Okay, so keep in mind then that in osteoarthritis has these ends being rubbing against each other, right? So ultimately, you're getting the wearing off of the synovial membrane right there, and then ultimately If that's allowed to continue, then the bones are going to go and rub against each other. Therefore, ultimately, rendering the person, essentially the joint, useless, right? Not the person, the joint. The joint is going to be rendered useless because, again, the bones are rubbing against each other. Recall that they have nerve innervation, right, which causes lots of pain, as you can probably imagine. Okay, so another stabilizing structure to joints is a ligament. All joints have an extensive network of ligaments that are essentially stabilizing the bones and keeping the bones together. So ligaments are also dense, regular, connective, collagenous tissue. But in their ligament form, they're going to go ahead and connect bone to bone. So they connect bone to bone. Towards the end here, I'm going to go ahead and go over the three freely movable joints of the shoulder and the hip. It's so the shoulder, the hip, and then I'm also going to go over the knee, the elbow, and the knee, if I'm not mistaken, at the end. And I'll show you guys the most important ligaments there and how they play a role. Tendons are also utilized here, but recall that tendons are mostly associated with muscles. So we'll come back to tendons when we're talking about muscles, because tendons originate and they support and they protect the muscle tissue, right? And then they connect over to the bone. But again, we'll come back to tendons later on. I'll mention them here and there in this lecture, but we'll have a full unit on muscles and tendons. Bursae is another structure that supports and protects. All right, so a bursae or bursa, right, is basically a synovial fluid structure. So it's kind of like a sac, if you will, that's filled with synovial fluid, which carries on with all the functions of synovial fluid, which is lubrication, transport of nutrients, and so on, but also support and preventing the rubbing of bones to each other, if you will. Right? Tendon sheath is part of tendons. Again, we'll come back to these later on, but I do want to show you, this animation here, showing you the bursae. Right? So bursae is many, bursa is one. So here you have a cross section of a bursa that occurs in the acromioclavicular joint. Here it is right here. Notice how it's separating the bones, and it's acting as a protective layer right in between the head of the humerus and the scapula. Right there. Okay, so again, what's it filled with? It's filled with synovial fluid. Therefore, the membrane itself is lined by synoviocytes.
Joint, the fibrous joint, and the cartilaginous joint. Let's start with the synovial joint, as it's the most common joint found in the human body. Synovial joints have several characteristic features, which we can see using this sagittal illustration of the knee joint. First of all, synovial joints are surrounded by an articular capsule. This capsule consists of an outer fibrous layer, which helps us to stabilize the joint, and an inner synovial layer, which absorbs and secretes synovial fluid, lubricating the joint. Next, it's important to know that the articular surfaces of a synovial joint are covered in hyaline cartilage. This cartilage is also known as articular cartilage and acts to reduce friction and assists in shock absorption. Additional structures may also be found within synovial joints, such as articular discs. We can see examples of these in the knee joint, the medial and lateral menisci. We may also see bursae, which are small sacs lined by synovial membrane and filled with synovial fluid. The bursae act to reduce friction caused by muscles and tendons, which are located over bony joints. Before we move on to the next type of joint, It's worth mentioning that synovial joints can be further subclassified according to the shape of their articular surfaces and their range of motion. These include the ball and socket joint, the hinge joint, the pivot joint, the gondola joint, the saddle joint, and the plane joint. We'll talk about these joints in more detail later on in our tutorial. Okay, let's move on to our next joint type, which is the fibrous joint.
All right. Okay, so the case study here, bursitis, right, is basically inflammation of the bursa. Anytime you see a word ending in itis, it's probably inflammation, right? So in this case, we have the bursa being inflamed by or undergoing inflammation by some sort of possibly an injury, right? Which could be caused by a very violent, drastic movement, such as pitching a baseball, right, for an entire baseball game that lasts, I don't know how many hours, 4 hours, not sure, right? So that could cause bursitis, right, which is again inflammation of a bursa. Osteoarthritis or rheumatoid arthritis can also cause inflammation of bursa, as well as infection. Okay, so moving on to synovial joints in terms of functions. So 4 classifications here, right? So 4 functional classifications of synovial joints: non-axial, uniaxial, biaxial, multi-axial. So as we go through these, we're also going to learn the specific types of movement that synovial joints allow. First is we're looking at the elbow joint right here. This is a uniaxial joint, which is acting like a hinge, if you will. Right? So another name for this is a hinge joint. So the movement here is in one plane, and the movement is going to be perpendicular to the axis. So here's the axis of the joint, and then look at the movement. It's the opposite, right? It's perpendicular to. Yeah. So this movement here is called a flexion. Right. So again, bringing the forearm up, it's called a flexion, and then putting it back down is essentially an extension. Then we have a biaxial type of synovial joint. Okay, the specific type here occurs in the metacarpophalangeal joint. So here's the metacarpal bones, 1, 2, 3, 4, 5. And these are the phalanges here, right? So phalanges are digits, and metacarpals are the bones connecting the wrist to the digits. So here's the joint. This is the plane, right, or the axis rather. So this particular type is going to allow 2 types of movement. That's what's called biaxial. First is, just like if you were waving, right, goodbye, if you will. Right? So bringing those phalanges forward right there is the first type. The second type is spreading out the fingers. Spread out your fingers in this manner, and that's going to be the second type of movement of the metacarpophalangeal joint, which is a biaxial joint. Third is the one that occurs at the shoulder, right? So this is a multi-axial type of joint right here, because it allows many types of movements, right? Even more than the ones that I'm showing here. The first is essentially a hyperextension of the shoulder, right? So you bring the arm to the back and forward, to the back and forward. That's movement along axis 1. Axis 2 is abduction, so moving the arm away from your body and then bringing it back. That's the second type of axis. And then the third axis is a rotation, if you will, of the humerus. Right? So you rotate the humerus in and out in this manner, and that's the third axis right there. Okay, so now what allows for this? If we look at the structure of the humerus, right, when we talked about that in the skeletal system, The humerus has a proximal head. Okay, it's got a rather large head that connects over to the scapula. All right, so specifically the glenoid cavity of the scapula. It's spherical essentially, right? So that sphere, right, that structure itself allows for all types of movements, which is similar at the hip joint. It's the same type of head. It's a spherical head, probably bigger than the humerus, but regardless, it's spherical and it allows for all types of movements. Okay, so getting into gliding movements and angular movements, right? So gliding would be non-axial, and this is sliding motion evidently between bones. Angular movements refers to increasing or decreasing the angle between the bones. So the bones over at the wrists, right, the carpal and the tarsal bones, all of them are gliding joints. Okay, all of them are gliding joints. So this particular one is called the intercarpal joint, right? And that is the same thing that occurs all over the bones of the wrist right here. So they basically glide along each other to be able to achieve the complex movement of the wrist. Okay, so again, a gliding joint. Alrighty, so now let's get into the angular types of movements, more complex types of movements here. So the subtypes are going to be flexion, extension, hyperextension, but there's a lot more than that. Okay, there's a lot more than that. So I'm going to go ahead and show you these three first. Flexion is decreasing angles, extension increasing angles, hyperextension going beyond, you know, what the normal joint could do. Okay, so here they are. Here we're looking at an elbow flexion right here. So again, you decrease the angle between the humerus and the radius ulna. Right? So that's a flexion. And then putting it back is an extension evidently. Right? So a hyperextension of the shoulder would be bringing your shoulder back as if you were scratching your back, if you will. Right? So you're hyperextending your shoulder right there. A flexion would be bringing it forward, but the entire arm without flexing the elbow. Just bring it all the way up. And that's a flexion of the shoulder. Okay, so you can also flex the hip in basically the same manner in which you do the shoulder, because again, it's the same type of joint right there. Flexion, you can also, you know, flex the head, and these would be lateral flexions to the right and the left. But you can also flex the upper body, and that is allowed by the limited movement of the vertebral column. So lateral flexion. Okay, so more specific types of movements. We got abduction, adduction. So abduction, ABD, right, is basically moving the body part away from the midline. So bringing that arm up laterally, right, and all the way up, that's an abduction right there. Bringing it back is an adduction, right? So you move it up, abduction. You move it back down, adduction. Believe it or not, there's muscles for both, right? So different muscles control abduction and different muscles control adduction. Again, we're not looking at muscles today. We're going to go ahead and look at those next time. Yeah, I think next time, if I'm not mistaken. Alrighty, so you can also abduct fingers and toes, right? Fingers and toes, you can go ahead and abduct those by basically, you know, fanning them out, distributing them outwards, right? So the opposite of that would be abduction. Lastly is a circumduction. So go ahead and, you know, rotate your entire shoulder joint, and you go ahead and achieve circumduction of the shoulder. Okay, so a very similar type of movement to circumduction is rotation, right? But rotation limits the body part right there, right? It limits the movement to just, you know, one or two bones. So here we're looking at the head rotating along the atlas and the axis vertebrae. The atlas and the axis vertebrae. The joint is called atlanoaxial joint. Recall that atlas is C1 and axis is C2. C1 and C2 vertebrae are basically allowing you to rotate your head. Okay, you also have rotation of your humerus, right? So you can go ahead and rotate your humerus by evidently using mostly the deltoid muscle right here. Deltoid has different heads, anterior, medial, posterior, right? So it allows you to go and rotate that humerus. Now, rotation of the feet is also possible there. So you achieve internal rotation, bringing that foot medially, right? Is internal rotation, and then bringing it back out is external rotation. Special movements, we have two: opposition, reposition, and depression, elevation. All right, so let's go ahead and look at them. It's better if we see them. So opposition, you're basically bringing your thumb, right, to touch your pinky, if you will. Right, so you touch your thumb to your pinky, and you achieve an opposition, essentially. Right? Reposition is bringing it back. So normal anatomical position here. Depression is moving moving the bone right here, in this case the mandible, downwards. And then elevation is moving it upwards. Very important movements when it comes to speaking and also in eating. So mastication requires depression and elevation of the mandible. Okay, then we get into protraction, retraction, inversion, eversion, right? Again, special types of movements. Protraction, for example, of the mandible is moving it forward, moving it anteriorly, and then retraction is moving it posteriorly, so bringing it back. Inversion of the foot would be angling it medially, and then eversion is the opposite type of movement, angling it outwards. And so inversion, eversion. We also have dorsiflexion and plantar flexion. So dorsiflexion reduces the angle between the metatarsals and the tibia, essentially. Reduce that angle right there. And therefore, you're utilizing the anterior tibialis muscles over here to go ahead and achieve that movement. Plantar flexion is the opposite. So you increase the angle between the metatarsals and the tibia. Therefore, you're not using these muscles, you're relaxing the anterior tibialis muscles. You're relying mostly on, on the calf muscles, if you will. Okay, so supination, pronation. So anatomical position, right, is naturally a supinated position, right? So this is supination right here. And you have pronation, which is the opposite. So the palm facing posteriorly. Okay, palm facing forward is supination. Palm facing posteriorly is pronation. All right, let me show the animation here real quick. Put things into perspective. Great, seriously. 13.
The joint may be slightly mobile, it does not perform functional movements. Therefore, I want to show you guys what I've been using to help me get rid of all those annoying ass little bumps on my face. Motion, we'll be talking about our freely mobile diatroses, or our synovial joints. The final way in which joints can be classified is according to their range of motion. When classifying a joint based on its range of motion, it's important to first understand the various axes of movement that the movements are occurring along. In joint movement, there are three main axes: the sagittal axis, which passes horizontally from anterior to posterior, the frontal axis, which passes horizontally from left to right, and the vertical axis, which passes vertically from superior to inferior. We can then describe joints by the number of axes they can move along. Joints that can move back and forth along a single axis are called uniaxial. Examples of these are the hinge joint and the pivot joint. Joints that move about two distinct axes are called biaxial. For example, the condylar joint and the saddle joint. Finally, joints that can move through all three axes are called polyaxial or multiaxial. The only example of this is the ball and socket joint. Okay, time to bring together what we've learned so far and take a closer look again at the most common type of joint in the human body, the synovial joint. Do you remember the 6 types? Let's start off with the ball and socket joint, which is also known as the spheroid joint. This is the only polyaxial joint, and therefore the most mobile of all joint types. The movements that occur at these joints are flexion and extension, which occur around a frontal axis, adduction and abduction, which occur around a sagittal axis, and internal rotation and external rotation, which occur around a vertical axis. For example, ball and socket joints are pretty useful when you want to play in the snow and make a snow angel. 2 examples of this joint are the acetabulo-femoral joint, otherwise known as the hip joint, and the glenohumeral joint, or the shoulder joint, which is shown here. Using the glenohumeral joint as a reference, we can see that this ball and socket joint has one ball-shaped articular surface, the head of the humerus, and one socket-like articular surface, the glenoid cavity. Next, we have the hinge joint, which has only one axis of motion, making it uniaxial. Hinge joints allow movement around the frontal axis, which passes transversely through the joint. Therefore, the movements that occur in this joint are flexion and extension. 2 examples of these joints are the tibiofemoral joint, or the knee joint, and the elbow joint. So we use our hinge joints when we show off, flex, our biceps. Like the hinge joint, the pivot joint is also uniaxial. So pivot joints, also known as rotary joints, allow movement around a single axis, this movement being rotation. The best example of this is the atlantoaxial joint, which occurs between the anterior arch of the atlas and the front of the odontoid process of the axis. The atlantoaxial joint allows us to show Let's move on to talking about the condylar joint, which is also known as the ellipsoid joint. Condylar joints allow movement around 2 axes that are at right angles to each other, therefore they are shown as biaxial joints. An example of this joint is the carpal joint, or the wrist joint. The movements that take place in this joint include radial deviation and deviation, which occur around the sagittal axis, flexion and extension, which occur around the frontal axis. This leads the movement to produce secondation of the wrist joint. So this is the joint passing length and synovially. Similarly to the condylar joint, the saddle joint is a biaxial joint. When this particular joint opens up at the ends of both, the root of the articular surface of the membrane and the complex articular surface of the bone, causing the connection of bone and fascia from the root. The movements that take place in this joint are abduction, adduction, flexion, extension, subduction. An example of such a joint is the carpal joint, which is the joint that sits over the lumbar spine. So this is the joint that allows you to take surface, but not without rotation. The final joint that we will look at is the pec joint, which is also known as the lumbar joint. This type of joint is unlike other joints we discussed in that it doesn't use an axis, but only permits movement when you retain a vertical surface. Therefore, it can be flexible, but also flexible at the same time. In short, the pec joint performs a very movement where one bone moves across the surface of the other. An example of this joint is the common lumbar joint, which keeps surface motion. The front line of this is about the size of a calculator, and the second line of this is during this lesson, I've clearly used evidence, but let's explain why some joints are necessary to maintain circulation and others don't. Ultimately, it's a trade-off.
Okay. So types of synovial joints. we're looking at a plain joint here, which is a gliding. This one has already been talked about. The intercarpal joint, again, gliding joint right there. Why? Well, because the bones are going to go ahead and glide on each other to go ahead and achieve their movement, right? Then we have a hinge joint, which is uniaxial, and this one occurs at the elbow joint. Okay, so what's special about this one is that the convex articular surface of one bone is going to go ahead and interact with the concave depression, essentially, of the other bone. Right? So that's what allows the movement of the elbow joint between the humerus, the ulna, and the radius. Right? The humerus contains a distal fossa right here posteriorly, which allows for the interaction between this part of the ulna here, right? As the ulna goes ahead and performs its flexion, evidently this olecranon right here is going to go ahead and move away from the fossa. But upon returning, right, that piece of bone basically inserts itself into a fossa that's located posteriorly and distally on the humerus right there, right? In order to allow for the extension of the joint. Okay, so yes, it is right a hinge uniaxial joint, but these markings here are very important in terms of accommodating the bones. Then we have pivot joints here, which are also uniaxial. The one we're looking at is the atlantoaxial joint between C1 and C2. Alrighty, so just wanted to show again, the marking known as the dens of the axis that allows for this pivot joint to take place. So this is basically one rounded end of a surface, one rounded end of one bone moving into a groove on a second bone. Again, very similar to what we saw in the elbow, but this occurs at C1. Notice C1 atlas with their facet surfaces right here, making a connection to the occipital condyles. Right, so just visualize, right, the big O skull right here on the top, resting on C1 through its occipital condyles, which join these articular facets. Condylar or ellipsoid joint is next. This occurs within the metacarpal phalangeal joints. So metacarpal bones 1, 2, 3, 4, 5, and them joining the phalanges makes up this ellipsoid joint. What's happening here? This is a biaxial joint, as we've already talked about. So a convex surface of one fits the concave surface of the other. Convex, concave, and again, that allows for the biaxial movement. When it comes time to go and fan out, right, to fan out the fingers, but also move the phalanges proximately, right, as if you were gripping something. Saddle joint is another type of joint, and it's a biaxial joint, which occurs in the carpal metacarpal joint. Right, so the joint between the wrist bones and the metacarpal bones, right here. That's the saddle joint. What makes this a saddle joint? Well, both have a concave and convex region here, right? So that allows for the biaxial movement within this joint. Evidently allowing the wrist to carry on with all of its complex movements. Then we have the ball and socket joint that you see at the shoulder joint, which is multiaxial, and the one you see in the hip joint, right, which is a very similar type of joint there. So this is axial rather, because it allows for all types of movements to be carried on, right, or at least most types of movements. Your flexion, extension, hyperextension, abduction, adduction, rotation, of the humerus and circumduction. All right, so these two tables are simply, going over the most important ones so that they're summaries of each one. We have the fibrous types of joints, sutures, gomphoses, syndesmoses. We have the cartilaginous joints, right? Synchondroses, symphysis. And then we have all of the synovial joints, right? Again, synovial joints are highly diversified, right? We have plane joints, hinge, pivots, condylar, saddle, ball and socket. Okay, so I just want to show you a very particular, very specific samples here, and then we'll go ahead and call it a lecture. What we're looking at is the elbow joint. So the elbow joint contains two smaller joints, if you will, right? It occurs between they occur rather between the humerus, the radius, and the ulna. Recall that the radius is on the thumb side of the arm, and then the ulna is on the pinky side of the arm. So they make at least two joints right here. They make the humeroradial joint, which is right there. So the humerus and the radius joining together. And the humeral ulnar joint, so the humerus and the ulna join together. Recall that these markings here are called epicondyles, and they're specific for making joints. So for building joints. So several ligaments here that we need to be familiar with. At least three. We have the radial collateral ligament right here, joining the radius to the humerus. Right. So the next one is the annular ligament. Notice how this ligament is, it circumducts essentially. It wraps around the bones here between the ulna and the radius, so stabilizing the two. And the last one, ulnar collateral ligament, joining the ulna to the humerus. Okay, so not the only ones, but the three most important ones that we have to be familiar with in terms of stabilizing the joint. We'll do other activities to go ahead and learn these ligaments here. As mentioned, right, the joints and the bones themselves accommodate the bone markings, right? I mentioned the olecranon of this bone right here, the ulna, right? As it's extending, as it's coming back from its flexion, it's going to go ahead and fit into a fossa of the humerus, right? So again, that's why markings become very important. Okay, I'm going to do my best here so everyone can hear, but it's going to be closed captioned. All right, so the little animation right there put together bones and muscles in terms of movement, right? Right now, we're not necessarily worried about muscles. We'll worry about those later. Right now, we're worried about the actual joints right there. Just wanted to show you the type of movement. The next joint is the knee joint. Right, so the knee joint creates several types of joints. The first one is the patellofemoral joint. Right, patella, or patella coming from the patella, which is the kneecap, and then femoral coming from the femur. And those two creating that joint right there is a patellofemoral joint. The other one is a tibiofemoral joint. So here's the tibia bone, here's the femur bone. The joint between the two is the tibiofemoral joint. So pretty generic names, right? as you might notice there, which is helpful when it comes time to learning those and remembering them. Alrighty, so those two are important right there. I don't know what happened to I had little circles surrounding the important ligaments here. But in this case, we have the patellar ligament joining the inferior aspect of the patella to the proximal tibia anteriorly, right? So notice how we're looking at this thing sideways, right? It's a cross section. It's a sideways cross section. We're looking at this thing laterally, right? So that's what I mean. The patellar ligament is located anteriorly, right? So if you were to, rotate this knee as if it were facing you, then the ligament joins together the inferior patella to the proximal tibia, but anteriorly on the front, if you will. Hope that makes sense. Oh, here they are. I was looking for these circles here. So here's the view that I was, referring to, but then this view cuts the patella and moves the patella out of the way so we can look at all the important ligaments that occur between the femur and the excuse me, and the tibia. Okay, so we started off here with the patellar ligament, right? This one has already been described. So inferior patella to proximal tibia. Alrighty, so now the top portion of it is actually a tendon. Okay, that's a tendon that comes from the rectus femoris muscle, which is the main muscle of the quadriceps, of the front of the leg, essentially. Right, but notice how we also have the cruciate ligaments. We have the posterior and the anterior cruciate ligaments. Both of those are internal ligaments, right? This particular one, the anterior cruciate ligament, the ACL, if you will, it's very prone to tears. I've known many people, many students who have, torn, if you will, this anterior cruciate ligament. It requires a pretty simple surgery, but nevertheless, the recovery time is kind of long. It's like 4 or 5 months, more or less. If you've undergone this surgery before, you know exactly what I'm referring to, right? So people can't after surgery, people can't step on this thing, right? They can't use the joint for 5 months at a time, right? Because that's how long it takes for the ligament to go ahead and repair, right? So, and that's with surgery, right? I guess you just immobilize yourself but you're gonna take longer to go and fix that. It's gonna take up to a year to go and fix that. Surgery helps in, and bringing the two torn ends together. Let me show you a better picture of that. Here it is. So they go in with surgery, and laparoscopic surgery. So they go ahead and go in. They go ahead and repair, right, the two ends right there and bring them together. And again, that helps the recovery time. It basically halves the recovery time. Okay, so anterior and posterior cruciate ligaments. Another ligament right here is a meniscus ligament. So the meniscus, we're looking at it right there. I didn't necessarily, circle it for whatever reason, but the meniscus ligament is a very important ligament that circumducts, this joint to help in stabilizing. The fibular collateral ligament is also important. We're looking at it right here. This is actual cadaver, right? So this one puts together the femur, the medial end of the femur, with the fibula. So medial distal femur with fibula right here. So that's the fibular collateral ligament right there. Again, also helping to stabilize the knee joint.
Muscles that act on the knee joint flexion and extension of the knee. Knee flexion is the result of the hamstring muscles as the prime movers. The gluteus and sartorius
It is. It's a set of 4 muscles, right? One is the rectus femoris. He called it the quadriceps femoris. Rectus femoris and vastus lateralis, medialis, intermedius. Those are the 4 muscles of the quads right there. The hamstrings have 3. The hamstrings are the primary movers of this joint right here. So they flex, right? The hamstrings are in the back. The quadriceps, they go ahead and extend this joint. Okay, we're almost done here, guys. Here we're looking at another view of the shoulder joint. What's important here is the glenoid cavity, first and foremost. Glenoid cavity is part of the scapula, the part of the scapula that connects over to the humerus in the ball or the head of the humerus, right there. Okay, so that makes the joint. The important ligaments here are going to be the glenohumeral ligaments, the coracohumeral ligament right here, putting together again and stabilizing this joint. So coracohumeral ligament, glenohumeral ligament. Gleno coming from the glenoid cavity. So basically joining the the lateral end of the scalp to the humerus. Coracohumeral joins together. Again, another marking of the scapula with the humerus. Here's another ligament, the coracoacromial ligament. And this occurs specifically on the scapula itself. All right, so there's a marking called the coracoid process of the scapula, and then there's another marking called the acromion process of the scapula. The subacromial bursa, so we talked about bursae earlier, right? Filled with synovial fluid right there. So you can see, right? You can see how it's right in between the scapula, located in between the scapula and the humerus right there. So as you're moving your humerus, right, all of that upwards force is being actually transferred by the bursae over to the rest of the shoulder, which includes mainly the scapula. But recall that we also have a clavicle right here. Just another view of the subacromial bursae, but this is a posterior view with all of the rotator cuff muscles right there. The rotator cuff muscles allow for circumduction and rotation of the shoulder joint. These are all the names right here, but again, we're not going over muscles today. Glenoid cavity again, can't stress enough the importance of the joint between the humerus head and the scapula. That's known as the glenoid cavity. The glenoid labrum is a ring of cartilage that's located in this region, also stabilizing, protecting, and reducing friction of the joint. Okay, why would we have the labrum right there? Well, it's a ball and socket joint, right? It allows for all movements of the pelvic girdle, essentially. I mean pelvic, I'm sorry. The pectoral, I'm sorry, girdle. It's quite a few movements, right? So we need extra protection. Therefore, having the glenoid labrum right there, a ring of cartilage tissue that protects a highly fibrous tissue.
The interactions of the 9 muscles that cross the glenohumeral joint are complex, and each muscle contributes to more than one movement. Additionally, movement at the glenohumeral joint can take place in all directions, where associated muscles can act as synergists in one type of movement and then antagonists in another type of movement. Therefore, 6 movements of the joint and humerus will be considered: flexion, extension, abduction, adduction, medial rotation, and lateral rotation.
Alrighty. So once we get to muscles, we'll learn how to increase the mass of those muscles right there that are the primary, secondary movers of joints, right? In case you're one who is looking to increase muscle mass, or maybe if you already practice that, maybe you can enrich the lecture, right, with your experiences in terms of building muscle and so on. So shoulder dislocations or shoulder separations, right? Dislocation of shoulder is basically specific to the glenohumeral joint. Again, glenoid cavity of the scapula and the humerus right there is the dislocation, right? The shoulder. Separation occurs at the acromioclavicular joint, right? Not the actual shoulder. Keep in mind that the clavicle is indirect part of the shoulder, right? The shoulder is deals more with the scapula and the humerus, if you will, in terms of movement. So separating these two, the clavicle and the scapula, that's more of a separation of the shoulder. Almost there. This is a hip joint right here. A few things of importance here. First is the cavity, the articular cartilage, right? Evidently the cavity for that occurs between the acetabulum of the coxal bone and the head of the femur. Again, the acetabulum and the head of the femur. A few ligaments of importance here. The ligament of the head of the femur is one important one. That is basically attaching the internal end of the acetabulum to a marking located right in that region of the head of the femur. Second is we have an acetabular labrum, again, a ring, fibrous ring that's protecting this space. We have the iliofemoral ligament, ilio meaning the coxal bone, the marking of the coxal bone internally. Femoral referring to the femur. So this, branching out and joining together the two bones. And then we have the pubofemoral ligament, pubal from the pubis symphysis, if you will. So this process of the iliac bone is called the pubis, joining to the pubis symphysis right there. Okay, so pubis to femur makes up, or is made up rather, by the pubofemoral ligament. Some other parts here, I've already talked about the acetabular labrum, right, which is that ring of cartilage that's important in stabilizing, protecting, reducing friction, and so on. Right? The ligament of the head of the femur, which I think I already said, attaching to the actual head of the femur, right, medially, and that putting it together to the acetabulum. And so here's a cut version of the ligament right there. Okay, so this right here on this side is actual cadaver. You can see clearly the acetabulum, the iliac bone or coxal bone, head of the femur, neck of the femur, trochanter, and so on.
The actions of the muscles that cross the hip include flexion, extension, abduction, adduction, lateral rotation, and medial rotation. Flexion of the hip joint results from two prime movers, the iliacus muscle and the psoas major muscle, with the adductor magnus, the pectineus, the adductor brevis, and the adductor longus muscle acting as synergists. Extension results from the adductor magnus as a synergist, and the gluteus maximus as the prime mover. Abduction of the hip from the anatomical position results from the gluteus minimus, the gluteus medius, the gluteus maximus,
So again, lots of muscles here. Just wanted to show you how they're involved in moving the joints. We will have an entire 2 or 3 lectures on just muscles themselves. So we have many muscles to learn, 600 muscles that we have to be very familiar with. Okay, so hip joint replacement is a case study, right? So hip replacement can be of the total, it can be total, if you will, total replacement of the hip, which is going to go ahead and modify the acetabulum, and then evidently change the entire bone right there, the femur, right? So they go ahead and remove the head of the femur, the neck of the femur, and they insert a, if I'm not mistaken, a titanium, if I'm not mistaken, type of metal there. That's very specific, and it looks exactly like the femur, essentially, right? They also have to modify, in the total replacement, they have to modify the acetabulum in order to make the head of the titanium femur fit the acetabulum now. Okay, so that's total replacement. There's also partial replacement where removes only the head of the femur, right? And then replaces it with a prosthetic device. For the most part, they use titanium, but nowadays, with advancements in medicine, there's many more options.